Psychosocial distress is common among oncological patients. It may result from problems in various parts of life concerning the disease itself, its treatment, family matters, working life, as well as institutional problems, communication, religion, and spirituality. Distress is an unpleasant emotion that may affect how patients feel, think, and act. As such, it also affects the coping abilities of patients. It has additionally been shown that a patient's quality of life is inversely correlated to the number of distress-related problems. For these reasons, it has become well acknowledged that a patient's amount of distress needs to be assessed. Given that human resources are notoriously limited, screening procedures have been designed to filter out patients with supportive care needs. Distress screening can be subdivided into routine screenings, case-finding procedures, and severity assessments. Health professionals wanting to detect emotional difficulties as simple as possible might use one or two simple questions, the so-called ultra-short screens. Those who want to identify and classify emotional disorders as accurately as possible might use a structured psychiatric interview. However, many patients who struggle emotionally do not meet DSM-4 criteria for psychiatric disorders. This has led both to the development of the concept of distress as the sixth vital sign and hence ultra-short screens, and also to a more precise delineation of mood disorders, including minor and subsyndromal variants. Common tools are available for detecting general distress, like the distress thermometer, developed by the National Comprehensive Cancer Network, NCCN, the Patient Health Questionnaire for the assessment of anxiety, among other psychiatric disorders, or the Beck Depression Inventory for a specific assessment of depression. As a statement of evidence and consensus, the distress thermometer is part of the clinical practice guidelines in oncology issued from the National Comprehensive Cancer Network. The distress thermometer consists of a scale ranging from 0 to 10, on which the subjectively experienced level of distress can be circled with a 0 representing no distress, and 10 extreme distress. A supportive care need is usually given if a patient circles 5 or higher. An additional symptom list allows the patient to check the parts of life in which they experience their distress, including practical problems, family and emotional or physical problems, as well as spiritual and religious concerns. For instance, child care or transportation, or concerning family problems, the ability to have children, or with respect to physical problems, fatigue, or memory and concentration. So what do you think? Do we offer counseling to all patients with high distress of 5 and higher?